Hello and welcome to the Therapeutics of Cardiac Failure in the Cardiology module. By the end of this session, you should be able to discuss the approaches to acute and chronic heart failure, explain the pharmacotherapy of cardiac failure, as well as outline the non-pharmacological management of cardiac failure. Let's get started. Acute cardiac failure therapy includes the treatment of hypertensive crisis, recanalization in cases of coronary artery disease, surgical cardiac interventions in cases of acute insufficiency or congenital defects, as well as the treatment of bradycardia or tachycardia. Management options in acute heart failure include oxygen, intravenous loop diuretics, opiates, vasodilators, inotropic agents if necessary, continuous positive airway pressure, ultrafiltration, or mechanical circulatory assistance such as using intra-aortic balloon counterpulsation or ventricular assist device. Consideration should be given to discontinue beta blockers in the short term. As for chronic heart failure, the causal approach considers the disease at hand. Revascularization in cases of coronary heart disease, as well as decreasing the risk factors, is part of cardiac insufficiency therapy. Surgical intervention, for instance, in cases of heart valve defect, is also part of the causal approach. Medical treatment conforms to the severity of the cardiac failure as defined by NYHA classification. ACE inhibitors or angiotensin receptor antagonists in case of intolerance to ACE inhibitors, which may cause a dry cough due to the buildup of bradykinins, are indicated as improving the prognosis in all classes. Starting with NYHA class 2, beta blockers and diuretics, as well as aldosterone antagonists and ivabradine are indicated. Cardiac glycosides such as digitalis will be used starting with class 3. Furthermore, cardiac resynchronization therapy to optimize cardiac contractions, implantation cardioverter defibrillator ICD, or a combination of both may be sensible. The last option remaining is cardiac transplantation. The NICE Guidelines has issued updated guidelines on the management in 2018. Key points are summarized here. Whilst loop diuretics play an important role in managing fluid overload, it should be remembered that there is no long-term reduction in mortality that has been demonstrated with loop diuretics such as furosemide. The first-line treatment for all patients is both an ACE inhibitor and a beta blocker. Generally, one drug should be started at a time. NICE guidelines also advise that clinical judgment is used when determining which one to start first. Beta blockers licensed to treat heart failure in the UK include bisoprolol, carvedilol, and nebivolol. ACE inhibitors and beta blockers have no effect on mortality in heart failure with preserved ejection fraction. The second-line treatment is an aldosterone antagonist. These are sometimes referred to as mineralocorticoid receptor antagonist. Examples include spironolactone and eplerenone, which should be remembered that both ACE inhibitors and aldosterone antagonists cause hyperkalemia. Therefore, potassium should be monitored. Third-line treatment should be initiated by a specialist. Options include ivabradine, sacubitril valsartan, or also known as Entresto, hydralazine in combination with nitrate, digoxin, and cardiac resynchronization therapy. The criteria to start ivabradine is the presence of sinus rhythm with heart rate more than 75 beats per minute and a left ventricular ejection fraction of less than 35%. As for sacubitril and valsartan, if the ejection fraction is less than 35%, this is considered in cardiac failure with reduced ejection fraction and who are symptomatic on ACE inhibitors or angiotensin receptor blockers. It should be initiated following ACE inhibitors, and ARB washout period. Digoxin also has been not proven to reduce mortality in patients with heart failure. It may, however, improve symptoms due to its inotropic properties. It is strongly indicated if there is coexistent atrial fibrillation. Hydralazine in combination with nitrates, this may be particularly indicated in Afro-Caribbean patients, and cardiac resynchronization therapy is indicated for those with widened QRS complexes on ECG, especially with left bundle branch block. If we look at non-pharmacotherapy, cardiac resynchronization therapy is one of the modalities. And again, this is indicated for patients with heart failure and wide QRS complexes. Exercise training also improves symptoms but not reducing hospitalization or mortality. So we have come to the end of the therapeutics in cardiac failure. Thank you for your time.